is a possible web case. We thought it's a good idea to go over the procedure planning a little bit. So I jump right into the procedure planning. I leave out the device introduction. Maybe I have later a chance to tell you about that too. So let's dive directly into procedure planning, get through the most important steps for that. So, as you know, I mean, the most crucial thing for the web planning is, for almost every luminal device, you have to get good imaging. You need to see what's going on, and you do actually two measurements in two orthogonal views of the aneurysm. And it's not important that these are your working projections. The most important thing is that these are projections that help you to understand the shape and the nature of the aneurysm you're treating. And the most important measurement for the web as such is the measurement of the aneurysm width. Because the web as a concept is like a cork. So the most important thing is it needs to cork the aneurysm neck, and it needs to have good wall apposition. That is what makes the web work. If you can cork something, you can web it. If you can't cork for whatever reason, you cannot web it. It's very easy as a concept. So when you look at a case, especially an early case in the experience, you have to look at the access that you have to this aneurysm, and this is what we discussed up front. The cases that we have here too. The size of the aneurysm, is it probably too big for a web? That can happen. Is it probably too shallow? These things can happen too. The symmetry, daughter vessel configuration, entry level, entry delivery angle, neck entry, aneurysm takeoff, the shape, dome to neck ratio is also important, and is it ruptured or is it unruptured? That's more important for the procedure itself, because the web is very suitable for both, even a very good device for unruptured aneurysms. So, best practices, we always recommend to use an intermediate catheter to support the via catheter to have enough stability when you deploy the web, but also if you need to resheath it, if you need to manipulate it, it's always good to have this extra on stability. Also for the measurement, you have to have these two orthogonal planes. I'll show you the measurement in detail later. This is a jump over this. And we recommend using the device selection chart that we developed for the web, because all the experience that we have for the web cases, the experience of over more than 4,000 cases went into that chart. Also the symmetry, you have to think about the symmetry of daughter vessels. If you have a different symmetry, you need to think about how you can position the web optimally. You can use the support of a balloon to deploy the web. You cannot change stuff after you have deployed the web with the balloon. You cannot put the web into the aneurysm with the help of a balloon. That doesn't work. And also the access angle is important. I mean, you can steam shape our via catheters, but you have to consider it before. Also, if you think about how you will deploy the web, the angle of access or the angle of attack is very important. So this is just a couple of aneurysms to treat with the web, and you always have to take into consideration. Interesting case is also this one, because it shows you something. When you measure the height, don't be aggressive. Don't measure the height where the web is not going to go. For example, if you think about the web, the shape the web has, it's never going to that cap. So don't measure that height for taking the web into consideration. That's important. Never be aggressive about height, by the way, but don't make any how do you say? I'm using the English word now. Use the right width. That's important. The width, again, it's a cork. The width of the cork is the most important thing, not so much the height. So, ruptured or unruptured, we recommend usually to get some experience with unruptured cases before you do your first ruptured case. The web is a very good device for ruptured aneurysms because of the antiplatelet regime. But to build experience, unruptured cases are recommended. What about the antiplatelet regime for the web? There has been a letter to the editor in the in a neuro journal from Spell and Liebig, and they recommended for unruptured, less complex pre-procedure antiplatelet therapy. Depending on the complexity, if it's less complex, do less. If it's more complex, do more. And the idea behind this is actually that should you need to change your strategy throughout the case, come to the conclusion you can't do it with the web, or you might need an additional stent, that you're actually prepared to do so. For ruptured cases, non-pre-procedure for sure is recommended, and post-procedure, what most centers do is a mono antiplatelet therapy like AS for 6 weeks. So let's go into the device selection and sizing. That's the most important thing, and we made it a 3-step process. You measure, you select which type of device you're going to use. There are 2 shapes of web available in general, and then you pick the right size out of the selection table. So the first thing to do, and I'm sorry that this here is disordered, the first thing you do is you measure in two projections the width, and it should be the whole width, not just like it is shown here. You measure the height, and you also measure the neck level. And in the second projection, you do the same thing. You also measure width, height, neck level, and these are the measurements you need to pick the right device. Here's just an example where we have a daughter sac here. Don't take daughter sacs into consideration. As the web is a cork that's going to sit here, everything that comes after the cork is going to be taken out of the game. So you don't have to think about the daughter sac in this case. If there are any questions, or if I'm too fast, let me know and raise your hand to ask questions. Or Marcus, as you're an expert, if you want to mention something additionally, please do so. Yeah?
Do you sometimes use a stent with the web, or it's always a balloon to reposition? Sometimes you're not happy, or you have a recurrence and it's about 12 months follow-up. Do you plan to put a stent also?
So in general, I mean, the good thing about the web is that you can deploy it, look at it, and you only detach if you're happy with it. If not, you can reposition it or even exchange the device if necessary. So the practice, and this is also what we see in our studies, is that we have a very low number of usage of adjunctive devices with the web. It's below 10%, and includes coils. So I would say that the rate of stents used with the web is below 5%, and these are cases where after detachment the physician was not happy with the patency of some of the daughter vessels, and then decided to use a stent to make sure that the daughter vessel stays open. But it's a very low number, and it's not what we recommend from the beginning on. The idea of the web is use one device and done. So if you plan a case with web and stent, I would be surprised if the web is actually necessary at all, to be very honest.
My question was, when you do a follow-up at 12 months or 24 months, and you see a neck remnant which is large enough, there if you want to put a stent, can you do it, or anyone else has experience?
Yes, I mean, I can Marcus let answer that, but I mean, we have seen a lot of, I mean, if there's a retreatment necessary, you have all the options that you need. Even surgery is a valid option, because the web can be very well compressed, compacted if this is necessary. If you need to clip, even that is open. So you have all the range, the full range of possibilities that you usually have in your practice. Do you want to add something, Marcus?
The stent is used as a bailout technique. For example, if you have stenosis in a branch. The balloon is used if you like to bring the web in a certain angulation. So let's say you can take the MCA aneurysm of today. So in this case, probably a balloon would be necessary to give the right direction of the web to the aneurysm. Otherwise, it's sometimes very difficult to bring it in the right direction. So, and if you have an recanalization or reperfusion after time, then it's, of course, it depends on the size, on the morphology, but usually then we use coils. You can use, of course, balloon-assisted coiling or stent-assisted coiling. It depends on the case.
As far as doing a balloon-assisted web or repositioning according to
Yeah.
what a technique, you inflate a balloon and then you deploy it, or you
Yes.
deploy and then
No. If you deploy the web first and then you use the balloon, you change the device. But if you deflate the balloon due to the 19-0 mesh, it will come back as it was before. So you have to inflate the balloon and then you have to deploy the web. Yes, if it's then first, of course, deflate the balloon, check if the position is okay, and then you detach. Yeah.
So exactly as said before, the purpose of the balloon is to change the orientation of the web at deployment. But once the cork is in, the cork is not going to go anywhere. So if you inflate the balloon, you compact the web, but once you take it away, it will go back into its main position. So after you measured the aneurysm, you take a look on what kind of device to use. We have two device shapes. We have the cylindrical shape here, the WEB SL. It's our standard device. It's used in approximately 85% of all cases that we do with the web are done with that solid cork, so to say. And we have another device which is the spherical web. This is why it's called SLS. The S stands for spherical. It's as spherical as the world. And the poles, it's a little bit more flat. This device is used if the neck is a lot smaller than the dome. So if the dome to neck ratio is significant, then you can consider this device. Or on elongated examples like this one, because it stretches much better than the cylindrical device does. But if you are unsure, or if you have a clear, very wide neck situation, tend to the volumetric shape, because that's what we use in 85% of all cases. So how do you size? What you do is you take, as I said before, and here fortunately the things are okay. You measure the two widths in the two perspectives, and you take the average width. In this case, 6.2. You go to the device selection chart. Here is average aneurysm width axis, and you go here to the 6.2. So it's going to be one of the 7 webs, web size 7 by something. And for the height, you have to take the smaller of the two heights. So and this is also here, it's mentioned here, smallest aneurysm height. The smallest height here is 5.1. So you go here and you see it's a web 7 by 4. Very simple with the device selection chart. Forget everything you heard before, and if anybody tries to tell you something else, that's the way to do it. Exactly. It's obsolete for a couple of reasons. The first reason is that we have smaller webs than ever before, and if you take an aneurysm that starts at 2.5, plus 1 is a much different animal than if I do plus 1 in a 9mm aneurysm. Very clear. So we do a lot less than plus 1 on small sizes, and we do even more than plus 1 on large sizes. As I said before, a lot of stuff went into this chart. So whatever anybody else tells you, whatever he does, don't do it. The chart is doing a very good job. Same thing actually goes for the SLS device. You also take the spherical, the round device. You also take the two average widths, and then you take a look for the smallest height that you have available, because For the SLS, I mean, as it is more or less round, we only have a single configuration. I mean, that's defined by the radius of the device. And there you have to make sure that you have enough space above, so that the SLS is not going to be too long. That's what you have to check here. You cannot choose by size because there's only one version available for the width, but you have to take a look that you have enough room for the web. And that's it practically. That's the device selection table. It also mentions average aneurysm width, smallest aneurysm height. So should you ever be unsure what now to do, should I average or should I take the smallest one? It is mentioned on the axis. It tells you by the color which via catheter to use. For some sizes we have 17 and 21 versions, but usually you have via 17. You also use the 17 for the 6 and 7 webs, the 27 catheter for the 8 and 9 webs, and the via 33 for the larger webs. And there's also one more important message here, and that's the stop here at 10 millimeters. If you have an average width of larger than 10 millimeters, 10.1, don't use the web. Very simple. It's a hard stop. I don't recommend using it over that. Results are not good. So there's a reason why there's 10.0. It says 10.0. So don't use it if the aneurysm is larger. Don't try to put coils next to the web or try something to fix that. It doesn't work. So that's the device selection table for the spherical web. Same thing here, 10 millimeters, hard stop. Don't go over it. So here's just an illustration. If you take care of the device selection chart does all the tricks for you. We have here a tube with 8 millimeter diameter. We put in an 8 millimeter web, a cork, which is not sufficient. If you put an 8 millimeter cork in an 8 millimeter bottleneck or in your wine bottle, it's not going to work. It's going to plop out or inside the bottle. And the same thing is if you put some weight on it, you see compression. If you put a 9 millimeter web into the same tube, you're going to see it's going to resist the weight much better. So this is the basic principle. The basic principle of the web. It's a cork, and every cork needs to be a little bit bigger than the bottleneck, and the device selection chart takes care of it. So, which also answers the question: if I have a partially thrombosed aneurysm where the thrombus is at the neck level, does the web work? No, because it's going to merge in. There's no volar position. It's thrombus. It's not going to work. Don't try. So procedural overview, as I said before, we strongly recommend an intermediate catheter, a 3-axial system for better support, especially if you go for the bigger catheters, but also for the via 17. Do that. This is a compatibility chart. I don't want to go through it with you now. I don't think we have the time. But all that information is available in the device selection cards that I showed you that we have upstairs in the control room, and which we have available. So all this information is always at your fingertips. And let me see, I should be able, that is a video, I should be able to start that from here. Yes. So, I mean, you peel off the small silicone cap. Don't twist, actually. She twists a little bit, not recommended. Put the detacher on, and if the light is green, everything is good. Don't bend or kick the pusher wire. What happens if you bend or kink it? Do this test again. As long as the light is green, everything is good. Do not kink or bend it back. Latest at that moment, the thing is going to be broken. So, as long as the light is green, everything is good to go ahead. If the light is red, exchange the detacher first. Try second detacher. If the second detacher shows you a red light, exchange the web.
Before you use the second one, I would dry it.
Yes.
If it's wet, then you can have the red light.
You're so right. I mean, dry connector. Always, before you put the detacher on, always wipe it dry. There is an urban myth that that a little bit of water helps the connectivity. It's not true. Electricity and water are not good friends. I mean, they are good friends, but not in our sense. So I think that's the same thing again. If the light is green, go ahead. That's important. So here it shows that you should advance the... it's not a movie, obviously. It is. Patient is ready. It is possible. It is possible. Yeah. Yes?
Time to time we see the aneurysm recanalization, but most of the time I call it growing aneurysm, and we have no the markers when the aneurysm growing, and we put the coil, and after 6 months we see the aneurysm bigger twice. There is no markers. Maybe we need to check on MR with contrast enhancement, vessel wall imaging, maybe, because in some cases we're positioned very well, but after time to time control angio, we see that web is not well opposed and the aneurysm get bigger. Yes, because the size of the web is 19 and it goes to the manufactured size, and usually it should be effective. Yes, but we have no markers, we have no analysis, testing to see the growing of the aneurysm. And for me, it's a big question. I have no answer for this question, because in many cases we place the balloon assist coil in bifurcation aneurysm, and in 1 year, no problem. In some cases, we do the same job, but very big regrow. I have no answer.
So thank you very much for that comment. Actually, this is something that I mention at every web training, and Marcos will go over the data, but the web is not a magic healing device. It does a good job, as we see in studies. I say it does it in 80%. It does a decent job. In 20%, it fails, and this is something you need to be aware of. So if you do 10 cases, you will see 2 where the web doesn't do the job. It's a statistical thing. We see it in every study we run. We run a lot of studies. That's what we see. It's a good result for wide neck bifurcation aneurysms, but it doesn't make you happy if you see it. I understand that totally. So. But not. So it's not web experience, it's a general experience, right? Yes. Okay, so then let's go upstairs.
And also we have light transmission in this room. It's comfortable view, and also we're joining the control room.
I can leave that here, right?
Yes, yes.